Our next witness is via WebEx, Dr. Jean-Jacques Rajter. Dr. Rajter is a Broward Health Medical Center physician who specializes in pulmonary medicine, internal medicine, and critical care. He previously served as the Chief Medical Information Officer for Broward Health and as an assistant professor at Drexel University College of Medicine. Dr. Rajter serves as a speaker for GlaxoSmithKline, AstraZeneca, and Forest Laboratories, as well as serves on advisory boards for Pfizer. His publications most recently include a study titled, quote, "Use of Ivermectin is associated with lower mortality in hospitalized patients with coronavirus disease," 2019, unquote. Dr. Rajter received his MD from the Drexel University College of Medicine and has accumulated over 22 years of experience in his field. Dr. Rajter.
Thank you very much. Honorable Chairman and Senators of the Committee on Homeland Security. My name is Dr. Jean-Jacques Rajter. I'm unfortunately unable to attend these hearings in person as I'm currently taking care of over 35 hospitalized patients. And it's an honor and privilege to stand here in front of the committee providing firsthand experience on the early treatment for COVID-19. My team has gained extensive experience with the treatment of COVID-19 in both inpatients and outpatients during this pandemic. Back in April, we were faced with a rapidly deteriorating patient population with no effective treatment. Extraordinary times call for extraordinary measures. I could not stand idly by as I've seen more people die in these last 6 months than I've seen in my entire medical career combined. Based on in vitro data by Dr. Wagstaff, my team was able to develop and implement an ivermectin-based protocol that showed tremendous success in treating COVID-19. This laid the foundation for the peer-reviewed ICON study, which was published in Chest, a major US-based medical journal. The overall mortality in that study decreased from 25% in the conventional care group to 15% in the ivermectin-treated group. In patients with severe pulmonary disease at onset, the mortality decreased from 81% to 39%. During the second wave of the pandemic, it was common for my team to treat in excess of 40 patients with COVID-19 on a daily basis. This ICON protocol has been optimized since, and we have learned a lot from our successes and failures. The success rate of the ivermectin-based protocol is now far superior to what it was in its early days. Ivermectin-based protocols have now been studied across the world, yet no major large-scale double-blind randomized controlled study has yet been published in a peer-reviewed journal. I will defer more review of the literature to Dr. Corey, who is going to be testifying later. Recent in vitro studies confirmed our clinical experience that the dosing regimen of ivermectin 200 micrograms per kilogram on 2 consecutive days was clinically effective. Of the hundreds of outpatients treated by my team, only 2, I repeat 2, were admitted to the hospital. 1 due to heart failure, the other one due to symptomatic delay of over a week before seeking medical attention. Neither one of them died. Neither one of them needed intubation. Both of them have now been discharged to home without complications. Ivermectin is a widely used medication with excess of 3.7 billion doses administered worldwide. It is currently part of the World Health Organization model list of essential medications. The ICON dosing regimen is based on currently accepted dosing regimen for Norwegian scabies. The dosing regimen has long-standing safety data. Safety of a medication is due to its pharmacokinetics and possible interactions, but not on its intended use. As is the case with any infection, early intervention has been proven time over again that is of critical importance. The same is true for COVID-19. Early intervention increases the likelihood of keeping people out of the hospital and hence decreasing the pressure on the healthcare system. Early intervention is cost-effective as it decreases the overall healthcare expenditure. Early intervention decreases viral shedding and viral transmission in the home setting, which is currently believed to be a major site of transmission. Early intervention increases survival. Early intervention decreases the economic impact. Notwithstanding impending vaccination programs, vaccines are not 100% effective and may not be widely available for many months. Many patients may be unable to take the vaccines for healthcare reasons or opt not to do so. Long-term immunity of these vaccines has not yet been documented. Based on these factors, treatment for COVID-19 will need to remain on the forefront even after vaccination programs are initiated. Ivermectin is effective in early disease, late disease, post-exposure prophylaxis, and pre-exposure prophylaxis. Ivermectin is an oral medication requiring no monitoring. Ivermectin is safe. Ivermectin is inexpensive and widely available. The US has spent billions of dollars on a multitude of treatment options. My team is ready to proceed with the randomized controlled trials to address any residual doubt relating to ivermectin use. Yet we're unable to do so due to lack of funding and support. A few $100,000 may definitively prove or disprove the effectiveness of ivermectin for early treatment with a properly designed and implemented randomized controlled trial. Funding, a little bit more funding, could look at the effectiveness of pre and post-exposure prophylaxis using ivermectin. A couple $1 million could complete a multi-center, double-blind, inpatient, placebo-controlled trial for ivermectin. Ladies and gentlemen, I implore you as a frontline provider of COVID-19 to do better, to provide us the answers we need as healthcare providers to help your constituents survive this horrible pandemic in great numbers. After personally witnessing the results of ivermectin-based protocols, I cannot stand by and allow hundreds of thousands of people to go untreated. Thank you. To clarify something, people talk about asymptomatic patients, but I have kind of stopped using that nomenclature. I call them pre-symptomatic patients. We do not know offhand which one of these asymptomatic patients are going to develop severe disease and become symptomatic. That is problem number one. Problem number two, when I put in my written testimony and also during my earlier testimony, I talk about the early intervention and treatment to decrease viral shedding and viral transmission in the home setting. And that is currently believed to be the largest numbers of people getting infected or getting infected in the home setting. So that means a 20 or 30-year-old may do fine, but now comes Christmas, there is a family meeting, and that asymptomatic individual now infects other family members, including their 70, 80, 90-year-old grandma, and now we have a real problem. What we do know about ivermectin is that it literally destroys the virus in most people within 48 hours. So hence, you take somebody who is asymptomatic, but a carrier with the risk of transmission, and you essentially stop that right in their tracks. So you don't have an issue about that person now contaminating other people down the line, or you significantly decrease that risk. So that is really even a very different spin on that question that was asked. Now, to continue as far as the data, you're right, Senator, it will be difficult. My team currently has a study in place. We have the protocols written, ready to go. The only limiting factor was to get funding. I've tried everywhere. Getting the funding is extremely difficult. What we need to do is a large study, a large randomized control study to confirm the findings, to prove to the naysayers, you know what? Here is your golden standard. Now, the study that I did was an observational study, but it was propensity matched. That is the highest standard for a non-randomized controlled trial. And even there, it shows tremendous benefit. You spoke about the reduction in the overall mortality from 25 down to 15. Well, if you look at the overall mortality in people with severe lung involvement, that went from 81% down to 39%. That is even a more dramatic decrease in even these more severe individuals. It is a safe drug, a track record that is phenomenal, 3.7 billion doses administered. So I think we need to do those studies with the help of the NIH, CDC, or any one of those regulatory agencies. A study like that could be implemented within 30 days. Within another 30 days from that, we could have collected all the data. Within another 2-3 weeks from that, we should be able to have answers. If things are moved forward through the regulatory agencies, we can have our answers before this tragedy even worsens. As a frontline provider, I have been treating COVID pretty much every single day since the onset. I've only had pretty much 7 days off since December 31st. Every other day has been taking care of these COVID patients in the hospital. This is heartbreaking. This is really difficult. Initially, we had to fight to get what I deemed appropriate treatment at the time. Now I have the endorsement of the medical staff at my facility who are using these medications. I have the endorsements of my colleagues who have seen the response of this medication. Ivermectin is effective. It's effective in early disease. It's effective in late disease. It's effective in prophylaxis. It's an oral medication. You do not need to monitor anything. There's hardly any interaction. You can use this medication in just about any condition, with the exception of people on warfarin. It is safe, inexpensive, widely available. Manufacturers are able to ramp up production of this if need be. Besides the US, it's something that could be implemented as a World Health Organization measure. The data is out there. The unfortunate thing is that we need more funding to be able to provide more studies, to look at people that are still naysayers. We need to get people at the regulatory agencies to review the current data, to see how effective this is, to talk to people that have been using this in certain areas. For example, compare the geographic area where I live and work with my colleagues to other areas in Florida. See if it actually makes a difference. Very easy to do. But I implore you, senators, to really help us, frontline providers, to get us the answers we need. I think we have the answers, but to prove it, to make other regulatory agencies come on board. Do not chastise physicians that have been thinking outside of the box, because honestly, the box has failed us. The medications that were promised to be the game changers to date have not done so. Remdesivir, convalescent plasma, to just name a few. We really need to attack this together, and we need to try to save as many people as we can, because I cannot continue to stand by and see hundreds upon hundreds of people die in hospitals, thousands of people, hundreds of thousands of people dying across the country. This is not sustainable. And there are easy solutions, inexpensive solutions, and it's time for people to start taking a second look at it and finally believing that this data is real, that it works. Thank you for giving us an opportunity to talk about this.
Thank you. And again, it seems like we have this pandemic playbook that we just threw out the window. And as I said before, I think the root cause of our problem is just closed minds.
Yeah.
I mean, people always preach at me like, follow the science. I think I do. I've got a very open mind. I realize that the term settled science is a very unscientific term.
It is.
We practice medicine, we keep advancing it, but you only advance it if you have an open mind. I'll never forget, in my previous life, I used to listen to a radio talk show, medical doctor, Dr. Dean Adele. And so many times he would say, when you hear hoof prints, think horses, not zebras.
Sure.
I think what has happened here is the people in the agencies, that they're all thinking zebras. They're all looking for the silver bullet solution, the exotic new biologic medicine, the perfect vaccine, when we've got a herd of horses that are just there, plow horses that can be used, and they're safe, and they're cheap, and they just might be incredibly effective, as Dr. Corey's talking about ivermectin, and others have argued on hydroxychloroquine and others. Why don't we look at the herd of horses?
Senator.
Tens of thousands, probably hundreds of thousands of people have lost their lives because we took the eye off the ball. We refused to look at the obvious and try and embrace what would have been the dream solution, something available, something cheap, something that would work. Why didn't we give it a shot? That to me is the question of this hearing, and I really have to go vote. So